Okay, I think we're going to go ahead and get started. So thank everybody for being here and getting your lunch. Appreciate it. So I'm very pleased today for our Talking Public Health seminar. This is our third. And we're very pleased to have Dr. Mengmeng Ji, who's a faculty member in the Division of Public Health Sciences at WashU School of Medicine. And she's an epidemiologist specializing in prevention and control of obesity. Oops, I didn't mean yay for obesity. I meant something I understand.
Control obesity.
Yeah, the control obesity, prevent it. That didn't sound very good, did it? It's, early in the week. And her goal is to provide insights into disease epidemiology and deliver evidence-based recommendations to policymakers right up the work we do, aimed at reducing health disparities and improving population health. So we're very pleased to have you here today. We're going to be munching a little bit. Ignore the potato chips.
Yeah.
People are talking, and we'll turn it over to you.
Thank you so much for the introduction. First of all, thank you so much for inviting me to be a part of the Talking Public Health series. I'm so glad to have the opportunity to share some of my research work, and then to have a discussion with all of you. So the title for my talk today is Harnessing Artificial Intelligence for Public Health, Applications in Obesity Research. So I got 40 minutes, and I'm going to share 3 studies of my projects that are involving using AI in my obesity research. To start, just a brief introduction of what's AI, machine learning, and deep learning. We have heard of those terms these years a lot. So it's pretty difficult to give a single definition for AI. It kind of include a broad class of computational method, but generally it refers to the computer system that able to perform tasks generally require human intelligence, such as perceiving the environment, reasoning, learning, and making informed decisions. And machine learning is a building block of AI. It's a subset, and it's kind of using the algorithm to allow the computer to learn from the data rather than explicitly programmed by human. So in the figure, you can see the traditional problem-solving ways, like we have data and then we write out the rule and then we got output. But for machine learning, it's like we have data and then we have outcome. We feed those data to machine learning algorithm, and the algorithm is able to find the pattern between input and output and provide us with the programming. And then we can use it to unseen data to answer questions. And deep learning is a subset of machine learning that is kind of like borrowing the idea of how the human brain works, like lots of neuron pathway the information to next neuron, and then to have a more solving more complex problem. So in the last years, we have witnessed the transformative role of AI in healthcare, such as how the computer vision is applied in the medical image to detecting early cancer, and how the deep learning model, such as the AlphaFold, it can accurately predict the structure of protein, and which really could accelerate the discovery and development of drug. And AI model is really good at dealing with high dimensional data, can be used to analyze those genetic data and then to enhance those personalized precision medicine, and of course other applications, including can help with patient education support and can optimize the healthcare system. So compared with AI in healthcare, the AI in public health is much less common. There are some, of course, but since my research field interest and focus is in obesity and obesity-related cancer, over the past years, we have been thinking how we can harness AI to offer innovative solution to tackle the obesity epidemic, which is really a major public crisis in the US and many countries too. It's projected that by 2030, which is 5 years later, half of the US adults will be obese. So It's related to lots of chronic diseases, including cancer. It's the leading cause of preventable death. So I did a quick search in PubMed using the simple term AI, machine learning, and obesity, trying to see what's the current trend of using AI in obesity research. And you see it's increasing. People are kind of being aware of we have additional tool to use. But compared to how big the problem is, it's still underdeveloped, and there are more potential that we can explore. So today I'm going to share 3 studies. I select them. I hope they cover diverse methods, like AI method, in the projects. Hopefully you will think they are interesting. The first one is building machine learning models to improve self-report and throughput measures. So in obesity research, we primarily rely on those health survey to collect self-reported height and weight to calculate the BMI, especially for national-wide. When you collect data for a large sample size, it can be expensive to objectively measure their height, weight, and BMI and such thing. But we know self-reported data they suffer from recall bias and the social desirability bias. People tend to report lower weight compared to the real. So the aim is to develop machine learning model to adjust or improve the accuracy of self-reported data. So we use National Health and Nutrition Exam Survey, the NHANES, 1999 to 2020. To our knowledge, this is the only national-wide survey that has both self-reported and objectively measured height and weight to answer our research question. So we exclude those who are younger than 80 years old and pregnant females. So we identify about 50,000 participants with both measure height, self-reported height and weight, and also a basic set of demographic information to help improve the adjustment. So we include age, gender, race, and ethnicity. We think those data are readily available in the survey to use. So the idea is we have input data and output. The input here is the self-reported data with demographic information. And the output is measured height and weight. So we feed those data to machine learning algorithm. We compare the performance of different algorithms and to identify the best performing model based on our evaluation criteria. So a brief introduction of the steps. So we need to have a research question, right? And we have data here is enhanced. And we select feature. The feature is self-reported data and a simple set of demographic. And then we split the data. We have 50,000. We split 80% to the training and 20% to the test. So the evaluation criteria here is the root mean square error. So it's the predicted height, predict weight, predict BMI, and the difference between real evaluated measured BMI. And then we feed to different algorithms, and we need to make some fine turn searching for the best hyperparameter to improve the model. And then we use the test data to evaluate the model performance. And we can use the model for unseen data in the future. That's the idea. So this table is the result. So we have separate model for correcting height, separate model for correcting weight, and a separate model for correcting BMI. And due to the time limit, I won't go to the detail how those algorithms are different, but we select the best one, which is the XGBoost. You look at a lot of number here. Just look at the result for the test set. So the root mean square error between predicted height and the real measured height is 0.02, 0.03 meter. And for weight is 4.5 kilogram, and for BMI is 1.89. So it seems to be okay, because it's the performance at the individual level, we get the average error. So it's hard to tell how good it is to use for our research purpose. So we further calculated this obesity prevalence, which is important. Like we use national survey to do the monitoring surveillance. We want to understand the percentage of people with obesity and then to inform the policy making and then resource allocation, right? So you can see here, like if we calculate obesity prevalence based on the measured BMI, it will be 36. But if we use the self-reported data, it will be 32. It's kind of underestimated based on the self-report. But if we calculate the obesity prevalence based on self-reported data, but corrected by our trained machine learning model, it's 36.05. Very identical. It's pretty identical to using the measured data. So it shows like the model is doing good, serving our aim. Like, okay, a short discussion. You can see that self-reported data is really underestimated. And of course, there are some statistical model. People are trying to work out a adjusted algorithm to correct those self-reported data. But machine learning is having its own advantage. Like it's better in capturing nonlinear relationship. Like it doesn't need the predefined assumption, like assumption of the parameter or the distribution of the data. And it's more adaptive. It's when we have new, like in the future, we collect more national survey data, and the self-reported bias trend may change. People may not. I mean, maybe in the future, people tend to report higher weight or whatever. So it's very easy to like fit the model with new data and then train it. So it's easier, adaptive to the new data. So, and you can see our model can be reliably to adjust those obesity prevalence based on self-reported data. So that's the first study. The second study is to use the deep neural network to predict obesity with short audio recording. The idea of this study is like we see some studies kind of looking for the relationship between voice and some disease, because the generation of human disease is a complex process that involving respiratory effort, the vibration, the phonation, resonance. So any disruption of those systems, those biological systems, may change the voice. A lot of studies find that mental health, depression is kind of impacting the way you speak, the pattern, and Alzheimer, Parkinson, and also some type of cancer is found like may lead to voice change. So the hypothesis of our team is like we are interested if obesity is related to voice change, like the fat deposition in the vocal folder or around the neck, or limited chest movement may impact the breath and the voice making. So it's the hypothesis. So we're trying to use the deep neural network to see if the voice can help us to determine the obesity status. So we conduct a web survey in Shanghai. We collect information of age, gender, self-reported height, weight. And of course, we want to exclude those people with a surgical history of laryngeal or pharyngeal. And importantly, we ask them to read a paragraph. We provide them with a paragraph, and then we ask them to read in Mandarin and then record them and send to us using their phone. So in the end, we collect data from 696 participants. 39% of them are obese, and then 61% of them are non-obese, based on the standard for Chinese population, which is 28 as the cutoff rather than 30. So we have recording. for each participants. So here we transform into two forms of data. The first one is spectrogram, which is the figure format data. And the second one is male frequency substrate coefficient. It's still numerical format data. So there is some way to extract the voice feature from the recording and then save them as a set of numbers to show the pitch, tone, or frequency pulse or something like that. And then we feed those data to neural networking, deep neural networking algorithm, and try to see whether it can predict people with or without. So here is the result. So for the spectrogram, we run the model using YOLO-8 and then convolutional neural network. And MFCC delta, and MFCC male, they are numerical format data. They just different way to extract those features, those vocal features. And I highlight the best model here. The overall accuracy is about 0.7, not that good. It's moderate. Here I want to briefly introduce the YOLO-8 model. It's a pre-trained model. So it was a model already there. It was trained using millions of pictures. It was really good at abstract detection and classification. So since we don't have a lot of data, we only have 700. It's not enough to train a really high accurate deep learning model. Usually require large amount of data set. So here we are kind of borrow the idea of transfer learning. It's pretty common strategy in using those AI models. Like we borrow those pre-trained models using large amount of data, and then fine-tune the parameter using our smaller set of the data. So as you can see, it achieving the best model, achieving the best performance compared to other models here. So a short discussion for this. You see, it only show a moderate accuracy, which is 70%, and it's doing good, better in identify people without obese compared to people with obese. Of course, our study as the first using computer vision to analyzing those obesity classification thing. It faces a lot of limitation there. We classify people into obese or without obese based on self-reported BMI, which of course is biased. And based on our theory, maybe better to classify them based on fat percentage, like more matching our hypothesis. And majority of them are female and young people, and the sample size is small. We only have 700, and we need to split them into learning and training, so it's even smaller. And the data, the raw data may have various quality because people record them using their own cell phone. So, but it lays foundation, like showing this novel approach can be promising in the future if we collect better, perhaps longitudinal data, like following weight gain or weight loss. We collect the data and having sample from diverse sample, and also maybe voice speaking English versus Mandarin may be different too. So, okay, the third one is use of automated machine learning to detect undiagnosed diabetes in the US adults. Obesity is the major risk factor for developing diabetes, and then it's recommended to screen for diabetes for those patients, for those people. However, screening for diabetes rely on blood test, and it's not widely followed. A survey showing that only 50 to 60% respondent report that they received those diabetes screening tests over the past 3 years, and the rate is even slower among those who living in underserved area or lower education income. According to the CDC data, like 23% of people who have diabetes didn't report or are not aware that they have diabetes. So the aim of this study is to develop an AI-powered screening tool that can help to identify or detect undiagnosed diabetes using self-reported data. And another aim for this study is to compare the performance of automated machine learning versus custom machine learning model. So what's automated machine learning here? Automated machine learning is a process that automating the task of applying machine learning to real world problem. So you see this pipeline shown in the previous study. So we need to select the feature, we need to split them, we need to fine tune and train and fine tune. It's a repetitive process, and then it requires the specialized skill and then coding. But using automated machine learning, all those steps can be automated. So the algorithm itself will find the best feature and then best algorithm, the model for you. So hopefully, and it can reduce human bias during the process and reduce the barrier to use those models. Like don't need to have a high level knowledge in machine learning model building manually. So for this project, we're also using enhanced data. We exclude those people who self-reported that they have diabetes. So all of them included in the analysis will be people who say they don't have diabetes. And we exclude those who have missing self-reported diabetes status and a missing lab test for diabetes diagnosis, and also younger than 20 years old and pregnant female. So in the end, we include 9,550 without diabetes. So they need to meet all of those three lab test criteria. And we include 2,256 with undiagnosed diabetes. So those people, they report they don't have previous history of diabetes diagnosis. But one of their blood tests, the glucose blood test, is meeting those diagnosis criteria. We pre-select a set of feature, self-reported data, including demographic and anthropometric measure, family history, lifestyle factors, dietary intake, and then a set of chronic conditions. And this is the result comparing automated machine learning and with other custom machine learning models. A lot of number here, but I highlight that automated machine learning model, they have best accuracy and the AUC. It's pretty impressive. Like using those self-reported data, we can achieve 86% accuracy. The AUC is 0.91. And looking at the confusion matrix of the performance on the test data, so unseen data of the model, the sensitivity is about 70%. Positive predictive value is 64. Specificity and the negative predictive value is pretty good. So the model is doing good in identify people without undiagnosed diabetes. Of course, it can be like improved in identify the positive, but as a screening tool, as a model for screening, those people can be followed with like a confirmative task later. So we also calculated those feature importance, because for deep learning model, sometimes it's hard to understand. It's like it works like a black box, like hard to know how it reaches this high accuracy, how it makes the decision. So this is the percentage of the importance of each feature or predictor. For example, for the age is 70.7. So it means like the model decision with or without undiagnosed diabetes is made based on the age, like for 70%, the information comes from the age. And the top 5 is age, weight, daily sugar intake, income, and the BMI. And this is the figure is too long, so I cannot have those under part here. When we include anthropometric measure and health behavior data, those comorbidity is less important, contribute less to the model. And then when we remove those comorbidity, we still got the model achieving accuracy of 85% and AUC of 83. I think the feature ranking is pretty reasonable based on the epidemiological study. So it's the model. A short discussion for this project is we compare automated machine learning model with those traditional machine learning model, and we find those automated machine learning model outperform traditional model. It's really reasonable because it was kind of like the decision or the outcome of automated machine learning is a group of models. So it's using the ensemble method. It's like getting a family of model and then to provide you the decision. So it's doing better than the traditional, and it's saving. I mean, it's making the machine learning model more accessible to us, like for public health researcher who kind of worrying about the required skill set to use AI or machine learning in their research. And then for the model we built, since we use Enhance, it's a national representative data, and then it's achieving pretty good performance. We think it could support large-scale diabetes screening in the future. Okay, so here are key takeaways from the project. I hope they are not overwhelming. And for the first one, the key message is that we have a lot of models, like statistical models, and machine learning models can really add to the toolkit of us to do public health research. It's doing better in identify the pattern in the data. Of course, it can be improved in explanation or interpretable way. But for some question, when we doesn't need, I mean, the accuracy is more important in some question, we can consider it as a really good option to use because it's better in capturing nonlinear relationship and it doesn't require a lot of predefined assumption. And for the second study, we are analyzing those voice data, and then we transform them into figures. And then we use the computer vision and deep learning model to analyzing those. So it really kind of broadened our research topics by enabling the analysis of different format of data, including text, image, audio, video, and other format, in addition to numerical. Usually for those traditional statistical model, we need to have those numerical format data. And the third project, we are comparing those automated machine learning model compared to traditional one, and then we see it lowered the bar to use the machine learning, and it's achieving even better performance in that research project. Currently there are more and more like AI user-friendly AI models, and as you see, for the transfer learning, there are a lot of well pre-trained model that we can borrow, and then it doesn't require a large amount of data anymore because not everyone has the resource to build such large model. So the key message for this project is we want to show AI actually is becoming increasingly accessible to public health researcher regarding the tool, the coding, how it can be automated. And even for coding, like generative AI can help space state. So all those three projects are kind of taking advantage of the ability of pattern recognition of AI. It's doing a really good job in this, and let's call it discriminative AI. And those three case study, just example, there are more and more potential applications that we can use in disease monitoring, surveillance, prediction, a lot of them. And not covered in my talk today is generative AI. There's an evolution in this field over the last years, and it's the Dr. Harold Joshua just mentioned the ChatGPT is a kind of like a large language model, and how it can help us to analyze data and then to generating whatever. It can be incorporated in different intervention projects, hopefully, to provide to help with factor checking, to provide like mental health supporting or education program, whatever. So there are many like huge potential here for adapting or harnessing those tools to our research. Okay, so I talk about the potential a lot, but those potential does not come without risk and challenges. Of course, we need to like be aware of them. Good model need have good data, come from good data. So a lot of time we need to deal with the missing and the data imbalance may like contribute to not can lead to a worse model performance. We need to know that, and the bias and the fairness. We need to have representative data, so the model or the algorithm is not biased. It shouldn't work better in some group and then not good in other subgroup. And transparency and explainability is another kind of challenging people are working on using those models, especially for deep learning. It's very complicated. It feels like it's coming from a black box. And so, especially in health, when you communicate with people about this result, the decision, to help them trust or like to convey them the result, you need to explain that. So there's a field is under developing, like the explainable AI is a field that people are working on, and privacy and security risk and ethical and legal consideration. So, but despite that, we have good aspiration for the application of AI for improving public health and hopefully to improve the access to those resources, especially for people who are in the underrepresented area, underserved area. So hopefully in the future, by ethical and responsible use of AI, we can like achieve a better public health, population level health. That's all for my talk today. And I would like to thank my collaborator, especially collaborator in China who collected data during the COVID. Like it's really challenging. Yeah. Thank you and welcome your question.
Thank you so much for speaking my language, so I appreciate it. Thank you very much. I'll stick with 2 questions, I guess. This was a great presentation. Just to make sure I'm understanding what you're saying, and maybe we're just using different terminology. By automated ML, are you describing unsupervised machine learning or?
Not really. Unsupervised machine learning or supervised machine learning, they all belong to the custom machine learning.
Yeah.
So you still need to like manually searching and fine tune your model, and then the automated one is really having those steps automated. So it's running a machine learning in an environment is already built And then you just said, okay, I want a run for 3 hours.
Okay.
Give me the best answer among those 3 hours, and then you're searching for the best model can best performance model using the test. So it's not a supervised machine.
And then maybe just speaking of the ethical considerations, so we were in conversation with the MIT when I was at Boston University with the MIT Lincoln Lab, because they wanted to use our cohort framing data. They wanted to use the voice data, like a off the record meeting, to actually try to use voices to identify relatives. They wanted to use it for mental health issues for people in the military, but also they were thinking maybe one day that would be helpful to identify the people coming across the border and then see who is relative to whom. So actually that would be like one source of data collection. And that on our end, at least, that made us very uncomfortable. And then it's like a starting conversation. And to them, I think that was like a less invasive way of collecting data than collecting DNA samples.
Yeah.
But I don't know if you thought about, but then we were thought all of this is going to go into the cloud. We know that was going to happen. But then again, to be fair, that is not now. That was an earlier conversation. If you thought about the ethical considerations of incorporating more data, like voice data, especially thinking about AI, what could be used for?
Yeah, I think a lot of things are really in its early stage, and for the regulation and for AI things, something really under hot discussion now. And for voice, of course, I think there's definitely related to the ethical problem. And some people say you may identify it. It can be like a fingerprint. You can like identify people using their voice or something like that. I just read a paper published by the Bridge to AI, the NIH Bridge to AI team, and then they are kind of like discussing how people think of voice data and how they are used. And for the ethical guidelines, I think they are calling for like more attention to this, and then hopefully develop such guideline in the future. But currently, there's not. Yeah.
You're not speaking my language. But I really enjoyed the presentation. I have a question about the first data set, and just thinking about over time with different body types kind of being in vogue, that the way people might stretch the truth around their weight may differ, may change, and how sensitive those models might be to being able to kind of rapidly change to whatever is in vogue, and how that's affecting social desirability biases.
Yeah, I think that's the one strength of machine learning model. Like you can really train the model again using more recent data you collected to capture those trends. It's really adaptive. It doesn't take long for me to train this 50,000, participants to get the best performance model. It's fast. But for the statistical models, you need to have, for incorporating new data to adjust, you kind of need to redo the algorithm, the equation, and it's not that adaptive for such problem, right? So yeah, we need to retrain that, or at least fine-tune using more recent data.
You're not speaking my language either, but I understood that, I think.
Okay, great. I was trying to reduce those technical parts. I'm not that technical person in AI too. I'm an epidemiologist.
So I'll just give an example that we're struggling with right now, and Rachel's going to identify. We do a lot with measuring childhood weight in one of the studies we have now. Weight trajectory, and we're working with mom and seeing if we can prevent obesity in these children from infancy on to about age 2 years. And we go back and forth with how to collect this data over periods of time. Self-report has issues with it. Trying to do distal measurements with mom is challenging, and we really struggled. And I look at this and I was thinking, oh my goodness, if there was some way we could get self-report from mom and do a correction like that. It would
Yes.
save tremendous money. It would enable us to really legitimately track these children so that we can see what's going on. How would that happen, and has that been done with children before? Because we don't have a huge data. I guess we could pull from Van Hayne maybe, but I don't know how we would do it. We start from infancy on up. I'm asking you to solve our research.
It's about consultation.
It's caused us in many a sleepless night.
Yeah, it's a hard question, but one implication that we write in the discussion of that paper is like, oh, we use self-reported, and then the model was trained using self-reported data and among adults. So in the future, we need to train like similar model using parents reported or children reported. The trend can be different. So as for the question about if we don't have a large amount of the data, we can borrow the transfer learning idea, right? Maybe you can fine-tune my model using your limit children reported data or parents reported data. But we need to see how it performs using the test, and maybe it performs good, or if not, I mean, good model really need good data. So perhaps we need to collect more.
You gotta get the good data.
Yeah.
That's the test.
So
But it has implications then,
Mhm.
because I could see where that would really help with some of the data collection. It would really be amazing if we could do some of that more effectively than we're doing now and more affordable.
Yeah, well, many applications there are there. I mean, we see the era, the time of changing, and then in the future, it may really transform the public health and maybe daily life. Like it's already happening. Like yeah.
So I was going to ask about her ultrasounds in Ecuador, but I wanted to get my question, first of all, thank you very much, Mengmeng. It was a very, I learned a lot in that presentation.
Well, thank you.
Yeah.
That's what I'm hoping for.
So my question is about the deep neural network in study 2, which to me, and you'll appreciate this as an epidemiologist, to me, it seems like that's a case control study, right? In design, you have obesity, non-obesity as your outcome, as your case and control, and then looking to see whether or not the voice is predicting that. Am I understanding that correctly?
I won't say it's a case control. It's more like a classification problem. So you want to classify people into different groups.
But you're using the model to look
Oh
at,
yeah, kind
in a
of
sense,
like what data we feed to the model is like to kind of label people.
Yeah.
Okay, this person is obese, this person is not, and then to find the pattern, like the difference between them. Yeah.
So the question is really about, as an epidemiologist, you would really care deeply about balance in those groups, right? Or the
Yes.
bias that and the confounding. So
Yes.
how does the model account for that? I mean, is it like the features and the?
Yeah, that's the problem I mentioned for the imbalanced data. I mean, this some challenging in health. Like a lot of time, the positive cases is much smaller than the
Right.
Yeah. There are a lot of like technologies developed. Yeah, some like trying to up sample or those minority group randomly.
Okay.
Or some like trying to synthesize, like the generate data for those, or some are trying to reduce the majority group to match to make the data balance. So very frequently method use is called smooth. So that's the problem. And then there are some technical solving for those. And I was trying to mention that for the second. For the automated machine learning, actually it kind of deal with those problems for you.
Okay.
So it was like, do you want to correct the imbalance, the coding? You said yes, it was kind of adjusting those issues for
That's
you.
handy.
Yeah.
So
Yeah.
So you don't train the model to do that. Like you wouldn't give it the feedback.
We do that in the second study. We only have like let's say 40% of people with obese and then 60% without. And we trying to increase the obesity group by doing some data augment. So we duplicate those figures, but adding noise to it. So it's trying to make the sample larger for those minority, the smaller group, and to make it like more balanced. Otherwise, if we have 10% positive and then 90% negative, if the model predicts everyone has no disease, it can still reach high accuracy, right? So we want to balance those groups. That's the problem we need to deal with during the training process. Yeah.
Thank you.
Hi, Mengmeng. Thank you so much. That was a fascinating talk. I have a more broad question about how we train students in deep learning and machine learning, and given the advances that we've seen in the last 5 years and how we're using AI for public health data, what do you see its role in how we train students, especially our data-minded students, maybe in epi and biostats? What do you see as the role of how we train them in the School of Public Health to use these models?
Yeah, I think training people to at least be aware and then kind of know there are many applications. What is really important, right, to prepare them for the future. I heard of what Dr. Ann said because we co-developed. No, he developed. I'm the teaching assistant for his AI class. He's saying like if we teach students, it's not his saying, it's the educator saying. If we teach today's students with how we trained yesterday, we are still there tomorrow. Like tomorrow, everyone in doing research will kind of, if you borrow the power of AI, you will increase the accuracy, you will increase the efficiency doing your study. And if your question is asking how we are going to train it, I think it's too big a question for me. Like we need to borrow that. We need to at least have some introduction level class for talking about this, and then students have developed interest, and then they can either taking class or self-learn. I mean, awareness is important. Open-minded is important to see the potential and then to learn this. It's very important to incorporate those class in the new School of Public Health. We need to prepare them for the changing future. Yeah.
Matt.
What? I'm in the same group that wants to thank you for teaching me things, and this was really helpful as a kind of an orienting presentation. I have a question about case study 2, also the voice data, classifying obesity, and I'm wondering if there was a gradient of accuracy, particularly in classifying people, for example, who self-reported much higher BMI versus BMI that was right around the margins. I mean, this classification is always higher, like especially in a dichotomous outcome, right around the threshold. So, did you see that in
the second study?
I think wasn't it case study 2 that was the voice data using it to classify obesity?
Yeah.
Yeah.
Your question is about the self-reported.
My question is about whether whether there was a gradient of accuracy. Like was the model better at classifying people with very high BMI than with sort of marginally high BMI?
Oh, yeah, it's possible. We didn't look like deeper into that. So we just calculate how accuracy it was grouped into 2 groups. So we didn't look at who is extreme. Maybe we don't have enough sample size. Initially, we tried to predict extreme, severe obese, but it will make each group sample size smaller and then reduce the overall accuracy. So in the future, if we have, of course, larger sample size, we need to have class 1, class 2, class 3 to see if it's doing better, identify higher BMI group versus like class 1 obese group. Yeah. So
Thank you.
yeah.
I also don't have a voice, but I have sort of a naive question. So to Matt's point, like, if your model isn't doing well in one particular group, maybe it's people who are like right on the border between overweight and obese, like, is it just a matter of getting more data to like really zoom in on that kind of a group? Do you need different types of data? Like, how do you solve a problem where your ML like isn't good at what you wanted to do?
That study is really a pilot study. You see it face a lot of limitation there. If the model is not good, I mean, we can add more features into the prediction. Currently, the project, we only use the voice characteristics to predict. Well, if we add more information like age, gender, or other features, we're trying to we could improve the accuracy in the future. Yeah, so there's a lot of work need to be done in the future.
I have a question about how you're using the term obesity. So can you go back to your figure with all those lines that predicted diabetes?
Predict. Sorry.
It looked like BMI was a relatively low on that list of things that predicted obesity. And I'm wondering.
This one?
No, in study 3.
Oh, okay. Is this one?
No.
It
next
had
one.
the bar graph.
There.
Oh,
So body mass index is far below waist circumference, for example. We
mhm.
know that obesity, BMI is a poor metric for obesity. And when you think about your first study, the goal was to predict BMI. But thinking about the data set that Haynes has around other measures that may give a better indication of a person's weight status, as opposed to just their BMI, have you thought about using a similar kind of, or developing a similar kind of model that could actually predict obesity as opposed to just BMI based on somebody's self-reported height and weight?
Yes. Yeah. So you see the first study example, we have the outcome is BMI, weight. We can have outcome as weight, and or fat like percentage using those BMI stuff, BMI or like to predict fat percentage thing. Yeah, of course. Yeah.
Oh, that's very, and I didn't start with this was a great presentation, but it was. And that is also very cool. Because, it's really easy to get someone's height and weight. It's harder to get somebody's waist circumference, their skin.
Yeah, actually, Enhance has the data.
Right. It's
we can use that. We can work on
it's all our but it would be so useful.
Yes.
To predict someone's actual obesity based on their self-reported height and weight.
Yes.
BMI is on fire all the time.
Right. It's not a good measure.
Actually improve obesity measurement worldwide.
Yes. Yeah. Thank you for the idea.
Thank you for this great presentation.
That's a great idea.
Yeah.
That's a constant argument that BMI is such a lousy measure.
Yes. Yeah.
See what you get for free when you come and talk.
You can solve the issue, problem.
Yeah.
Yeah, I'm happy to.
Yeah. Any other questions? Well, thank you. That was really great.
Thank you. Thank you all.